And just to wrap up, let's just talk about some future directions and thoughts about, where the field is going, specifically for patients with early stage resectable non-small cell lung cancer. From a treatment strategy standpoint, I think chemo IO, neoadjuvant, perioperative is here to stay, requiring, that multi-D approach and communication as we were talking about. We're seeing, subcutaneous immunotherapy, rolling out to clinical practice. Coral, do you see an advantage for subcutaneous immunotherapy in the setting of these strategies? And how do you think that'll be used in the clinic?
Like now that we have like subcutaneous Nevo, I think it's something that we always bring up to the patients. I think it's really like a 50-50 whether they're, sorry, it's not Nevo, it's a Tezo. Right, Ticiana? It's a Tezo?
And
Okay.
Nevo, I think Nevo will have it as well.
It's on the way, but right now it's
Yes.
so. And so we really bring it up to the patients. It's something that we offer. I would say it's like 50-50. The patients that are, I thought they were gonna be like super excited because it's a quicker, like a shorter chair time and like a quicker injection and that's it. But some of them are like, no, I actually like to sit and just like I feel more comfortable with like a slower infusion. But in terms of the patients that are maybe younger, that mothers with that don't have childcare, for patients that really have to work, right? Like we have a lot of those. I think it's something that's definitely useful and beneficial. I think anytime that we can give them options really is something that I'm all for and inclined to do.
Especially like in the adjuvant phase where you're getting just monotherapy IO that
Yes, you
has
come in and out in like a few minutes. It's almost like radiation.
and I think the future might be like home care and you can
Yes.
actually get your injections at home and not even have to like come in as long as you have telemedicines and monitoring the patient. You've got to obviously have a lot of education in place and care, but I think that's really interesting. So to just wrap up, any final thoughts from all of you in terms of what are your hopes and future directions in terms of what you want to see for research in this neoadjuvant perioperative space?
I think I not to be redundant, but I think really more like longer studies and prospective studies and longer follow-ups for ctDNA. I really think that that's where the future is going to lie. It's going to really give us much more confidence in guiding the decision making. And I think not only to guide like the neoadjuvant versus perioperative approach, but like we spoke earlier, really like blood assays for screening. Unfortunately, not only are we missing people that are eligible, like Dr. Antonoff said, we're also like a lot of people that are ineligible, that are at high risk. So hopefully incorporating some of this blood-based assay into early screening, at least to stratify patients that might benefit from low-dose CT versus not. Just like you guys, screening is something that I'm really passionate about, especially in Hispanics. And so I think just giving the opportunity for more patients to be able to and like have the neoadjuvant or perioperative approach is just, we need to really keep fighting for that early staging and early detection.
Robert, you next. Thank you for that, Coral.
Yeah, no, as Coral mentioned, I'd like to see a very like a validated circulating tumor DNA assay that can determine who has, metastatic disease when they present with quote unquote early stage lung cancer. I think that would be a great tool to help us, in terms of decision making, in terms of neoadjuvant treatment, the best regimen for the individual patient. And also, I think, I would like a better biomarker for immunotherapy. I think PDL1 is, sort of okay biomarker, but there must be something in the tumor microenvironment that we can, use to help better select patients and determine, if they would be good responders to immunotherapy. I'd like to really see a better biomarker for immunotherapy.
Excellent. Mara, your turn. Thank you,
Uh,
Robert.
Great thoughts. I'd echo both what Coral and Robert have said. I think ctDNA has a long way to go and it will be useful. I was thinking about biomarkers as well. I think it's not only important for us to have an idea of who are going to be the really good responders to IO, but also to understand who's going to receive no benefit. That's almost the more dangerous things, that we aren't wasting time on a treatment that isn't helpful. And I think, we've started to realize that people with specific driver mutations aren't likely to respond well to IO, but we don't even know all of the mutations. We don't even have like a tip of the iceberg of all the different mutations that our patients may potentially have. So as our molecular profiling gets better and better, hopefully we'll be able to really determine each individualized, true, personalized genotype of their tumor and be able to figure out which things are going to be helpful, but also which things are not going to be helpful at all. So we don't waste any time treating them with something that has potential toxicities without any real benefit.
Yeah, I completely agree. I was thinking the same thing, like impact of co-mutations that we know in the advanced setting can be negative co-mutations like the STK11, the KEAP1. And also, one thing that I'd like to see more of is having more CNS endpoints in terms of, decreasing CNS recurrences and using strategies that have more efficacy in the CNS as well, to decrease CNS recurrence. So this has been a great discussion. I want to thank all of you, Mara, Robert, Coral, for joining us today in this great discussion, and I hope you all enjoyed it as well. Thank you, everyone.
Thank
Thank
you.
Thank you.
Thank you.